Good morning. My name is Sakil Kulkarni. I'm at Washington University in St. Louis, and today I'll be speaking on utilizing predicting scores in chimeric sclerosing cholangitis. I have no financial relationships to disclose. So, predictive analytics is a science of predicting a future outcome based on current or historical data. This slide outlines the basic steps which one takes in predictive analytics. So current or historical data, which could be clinical, laboratory, or radiological parameters, are subjected to statistical analysis with methods such as logistic regression or newer machine learning methods like random forest analysis to identify predictive factors predictive of a chosen outcome, which in case of PSC could be GGT, bilirubin, or presence of esophageal varices. And a composite of these predictive factors is put into a mathematical score or a predictive score. For example, in PSC, the Mayo score or scope index are examples of such scores. And then once a score is derived, it's put to it undergoes validation in an external cohort, and a C statistic is calculated, which I'll be talking about in the next slide. While examining studies relevant to predictive analytics in chimeric sclerosing cholangitis, a few things need to be taken into consideration. Some studies exclude individuals with small duct PSC and autoimmune hepatitis PSC overlap. Although they may not be as prevalent in adult population, they are important for pediatric PSC population. The outcomes which are predicted could be liver transplantation and or death, hepatobiliary complications such as portal hypertension, biliary complications or cholangiocarcinoma, or radiological progression. The outcomes predictive may be short term, which is 2 to 4 years after diagnosis, or long term, which is 8 to 10 years after diagnosis. A C statistic is usually calculated, which refers to the probability that a randomly selected patient who experienced the given outcome or an event has a higher score. So higher values for C statistics means a better model. Now, why are PSC prediction scores needed in the first place? We all know that PSC has a variable disease scores. Shown here on the left is survival with native liver in pediatric PSC patients. And as you can see that about 85% of pediatric PSC patients and about 70% of pediatric PSC patients are alive with their native liver at 5 and 10 years after diagnosis. Shown here on the right is a Kaplan-Meier curve demonstrating event-free survival, and events means hepatobiliary complications such as portal hypertension or biliary strictures or biliary complications, which shorten survival with native liver. And as you can see, about 30% of patients and about 50% of pediatric PSC patients experience an outcome at 5 or 10 years after diagnosis, respectively. So our ability to predict short-term and long-term survivors with native liver or without a hepatobiliary complication may help us understand disease progression better and help us understand have better conversations with our parents and patients in clinic. This is an example how PSC prediction scores can be used in clinical trial design. For example, a newly diagnosed PSC patient can have a predictive score with superior discriminatory capability, such as a scope index calculated at the time of diagnosis and classified either as low risk or high risk. Coexisting conditions or complications of PSC, such as cholangitis, autoimmune hepatitis, dominant strictures, and colitis can be treated, and the patient can be then reclassified about 6 to 12 months after treating this as low risk or high risk again, and then considered for referral in phenotype specific clinical trial. For example, PO vancomycin in low risk PSC patients. These are examples of adult PSC stratification efforts which have been taken over the last couple of decades. Adult PSC patients have been classified either as low risk or high risk based on either non-modifiable risk factors such as patient sex, IBD phenotype, or based on lab parameters such as liver enzymes, biliary markers, and clinical parameters. Some examples of these are serum alkaline phosphatase, Amsterdam Oxford score, the short-term predictive UK PSC scores, revised Mayo, score or the Boberg model. The extent of biliary disease on EICP or MICP can be used for predictive stratification as well. The extent of parenchymal fibrosis can be used. Some notable examples are elastography. Enhanced liver fibrosis score has been used, the Presto index, which was developed more recently, and UK PSC score to predict late outcomes. And then finally, markers of advanced disease such as bilirubin, albumin, and MELD score in adults. Shown here is a commonly used biliary marker GGT and its predictive value in pediatric primary sclerosing cholangitis. On the left, you see this Kaplan-Meier curve, which shows that if a particular child has a GGT reduction of more than 75% at 1 year after diagnosis, shown here in the solid line, the probability of surviving with native liver is much better than if this endpoint is not achieved. Similarly, on the right, it's shown that if the absolute GGT value at 1 year post-diagnosis is less than 50, regardless of treatment with isodeoxycholic acid or not, shown here by these two solid lines, the probability of survival with native liver at 5 years post-diagnosis is good. Based on a retrospective cohort, Mark Dinu and colleague derived the SCOPE index of the sclerosing cholangitis outcomes in pediatric index, and the attributes which go into calculating this index includes total bilirubin, albumin, platelet count, GGT, and cholangiography, which means presence or absence of large duct disease. Values for each of these is assigned a score, and then a composite of this goes into calculating the total score. A score of between 0 to 3 is classified as low risk, between 4 and 5 as medium risk, and between 6 and 11 as high risk. And based on the total score, the probability of having a transplant or a liver-related death in the next 5 years can be estimated in low, medium, or high risk patients, as shown here. And similarly, a probability of having a hepatobiliary complications in the next 5 years can be calculated as shown here. Now, Mark Dinu and colleagues in another recent paper did demonstrate that the SCOPE index performed much better in pediatric PSC subjects compared to other adult score. Shown here is this graphic with the C statistic on the Y index on the Y-axis, with 0.5 being no discrimination and 1 being perfect discrimination, and on the X-axis you see years post-diagnosis. You see here in the blue and the green lines, which indicates that the SCOPE index at the time of diagnosis and at about 2 years post-diagnosis performed much better than all other adult PSC predictive scores in pediatric PSC patients in predicting outcomes at 5 and 10 years, so short and long-term outcomes. Pediatric patients undergo an MICP at the time of diagnosis of PSC to classify the patient either as large duct or small duct. There are MRI-based scores which have been derived in adults and in pediatrics, which have been used to predict outcomes. Shown here is an example of an adult PSC score. On the left is a patient who had a low cholangiographic-based score, and you can see the stable disease with identical pictures 5 years post-diagnosis, while on the left is a patient who had an advanced MRI PSC-based score, and you can see that the disease has progressed as shown by the nodular liver and presence of ascites. In summary, PSC prediction scores can help understand disease behavior better, can help design clinical trials, can help facilitate discussion with patients' parents in clinic. SCOPE index performs well in pediatric PSC patients, but need validation in a prospective cohort. SCOPE index should be calculated at the time of diagnosis and 2 years post-diagnosis, and then MRI-based scores can potentially help supplement SCOPE index. Thank you very much, and I look forward to our discussion later today.
Thank you for the opportunity to speak to you about predicting remission in autoimmune liver disease and to describe a fascinating and promising multi-center effort in that direction. I have no disclosures to share with you. I think we can agree that for many of us in this group, one of our common goals, to borrow a phrase from our gracious host institution, is to change the outcome together. Now, applied to autoimmune liver disease, particularly in childhood, what can that mean? When I spoke here last year about outcomes in autoimmune liver disease, I shared this list from a paper by Maria Green and Peter Whittington. And of the 8 relevant outcomes they named for pediatric autoimmune hepatitis, they placed remission first. What defines remission? If we look at the literature for autoimmune hepatitis, it is usually something like normal transaminases, normal immunoglobulin G, negative or very low autoantibodies. And for PSC, the GGT has become a central part of our concept of remission. And there may be other factors that might one day become part of the definition, imaging parameters, other biomarkers, and then why not certain clinical features or health-related quality of life. But for this talk, we will base the definition of remission on blood test results. Why is remission important? One simple answer would be whenever we are faced with a disease that is treatable but not curable, remission may be the best we have to offer. But more precisely, remission has meaningful implications for a patient's future, as shown, for example, in this large retrospective study by Porta and colleagues, which came out earlier this year. Remission during treatment was one of the best predictors of transplant-free survival, whereas patients whose ALT had not yet normalized at that 6 months of treatment had worse outcomes. So yes, it clearly is important. But who will achieve it? How do we know? Can we tell from clinical scores, such as the autoimmune hepatitis score, or from immunologic markers, such as interleukin-2 in serum? Are there other biomarkers that let us predict a good treatment response? There are some data, but there really is not much published in children, and ultimately no one knows for sure. And that is why we are so excited that our own autoimmune liver disease network for kids, A-Link, affords us a unique opportunity to combine our forces and our resources and really study these questions in detail and in a large patient cohort. A-Link, as all of you know by now, currently consists of 11 centers across the country, and we actually had decided quite a while ago that one of our first efforts should be a retrospective study of our pediatric autoimmune liver disease patients. I remember that one of us called it the low-hanging fruit at that time. After quite a bit of work, I'm not so sure just how low this fruit is actually hanging, but it was a very good way to start nevertheless. You see the various investigators at the different centers on this slide. I must give a big shout out to Amy Taylor, who has worked tirelessly on this project and really has inspired us with her leadership. And although I guess he's not technically one of the principal investigators of this retrospective study, it won't surprise any of you to learn that Alex Mietke has been absolutely instrumental in conceiving and developing the study. So what is it that we want? First, to determine in a retrospective cohort within our A-Link network, the percentage of children with autoimmune hepatitis or PSC who are in biochemical remission at 1 year and subsequent annual visits. Second, to identify which predictive factors may be associated with achieving complete or partial remission 1 year after diagnosis and with disease flares thereafter. Third, to determine the percentage of children with clinical endpoints related to the liver or the biliary system, extrahepatic autoimmune disease, and adverse effects from corticosteroids between time of diagnosis and most recent follow-up. I will explain what that means later in some more detail. And finally, because this is 2021, to look at the effect of COVID-19 infection and SARS-CoV-2 vaccination on either pre-existing or newly diagnosed autoimmune liver disease in children. We plan to review the electronic charts of approximately 750 patients, 2 to 21 years of age, with autoimmune hepatitis, primary sclerosing cholangitis, or autoimmune sclerosing cholangitis, formerly called overlap syndrome, over a duration of 20 years, or whenever the current electronic medical record system was first introduced at that study site. We are going to query the EMR for 6 different disease codes that should, we think, capture pretty much all patients of interest, and then enter the data into a shared database using REDCap. We will then look at remission rates and try to identify predictors. We will also look at COVID-19, its severe form in children called MIS-C, and vaccination against SARS-CoV-2. We will ask, when was biochemical remission first achieved? For autoimmune hepatitis, we will use ALT, AST, IgG, and autoantibodies. And for sclerosing cholangitis, we will look at the GGT. We will then compare remission achieved versus not achieved, and remission sustained versus disease recurred, and correlate the dichotomous outcomes in each of these pairs with demographic and clinical factors to try and identify predictors of remission. In the first year after diagnosis, we will look at time points roughly every 3 months, allowing for some leeway, afterwards just annually, and document lab values, medications, clinical endpoints, imaging results, findings from procedures, and histology from tissue specimens. We will also record anthropometrics, growth measures, autoimmune diseases affecting organs other than the liver, unwanted effects from steroids, and, as I mentioned, data related to COVID-19. And this slide just lists the most important complications, side effects, and secondary diseases that we will be recording. You're all quite familiar with these. And again, for COVID-19, we will look at the infection itself, as well as the vaccines, and if and how those might correlate with autoimmune liver disease. To analyze the data, we will first use descriptive statistics and then logistic regression to identify predictors of disease outcomes. In addition, we hope to be able to use natural language processing for text analysis of narrative or descriptive data elements in the patient's medical record, and deep learning methods to help us understand the natural history of the disease and how it is changed by the drugs we use to treat it. Where do we stand with all of this? Well, I'm happy to report that the IRB application and the CRF are both finished, so we are ready to go and are in the process of submitting the documents to the local IRB offices at our centers. We hope to have all the data collected by the end of the year. Ambitious, I know, but we believe it can be done. Looking ahead, this is, I think, a very exciting and meaningful project that can give us a broad and deep, detailed set of information about a large cohort of children with autoimmune liver disease. We believe that sophisticated analyses will show us predictors of remission in our patients, which may then inform our prospective A-Link study and ultimately improve patient outcomes. Thank you for your attention.
Hello and good morning. First and foremost, thank you and so much for Alex and Amy and the whole Pediatric Autoimmune Liver Disease Symposium team to invite me to present today. I'm Haley. I'm one of the pediatric gastroenterologists and a hepatologist at University of Minnesota. And I'm going to talk today about patient-reported outcomes and health-related quality of life in patients with autoimmune hepatitis and PSC. I do not have any disclosures. The objectives for today's talk is mainly briefly talk about the instruments to measure these outcomes and whether we have good ones or we need more of them. Then to discuss what are these outcomes, as in what are these physical and emotional symptoms felt by our patients. And then last but not the least, what is the impact of these symptoms on patients' life. So we only have two formally validated tools in PSC, the best and the most promising one of which just came out a couple of years ago. It's called PSC Patient Reported Outcomes Tool. It is a promising tool in that it was designed with patient input and it had good internal validity. It does require further validation in large, diverse population, and it was lacking some of the IBD related questions, which might be good to include. We unfortunately do not have any in autoimmune hepatitis. The other validated tool in PSC was the one developed by National Institute of Diabetes and Digestive and Kidney Diseases. However, it had poor internal consistency and retest reliability in our population with PSC. This, when compared to other chronic diseases like cancer and cystic fibrosis, needs a lot of work and a lot of development of some ideal tools to help with other patients who have chronic liver disease as well. What basically included in PSC patient-reported outcomes tool were a couple of modules. So in module 1, patients were asked about the severity of their specific PSC symptoms on a scale of 0 to 10. And within a 24-hour recall period. The symptoms mainly included things like abdominal pain, discomfort, itching, fatigue, jaundice, difficulty with concentration, nausea, fever, chills, and sweats, and the maximum score was 120. As you can see in this bar chart, A is the representation of scores from this module 1, and it was quite skewed towards the lower side, which means that our patients were relatively well controlled. In module 2, patients were asked about the impact of PSC on their daily life. This module included 7 4-item domains covering various aspects of patients' functionality and well-being. So physical function, daily living or activities, work productivity, role functioning, emotional impact, social leisure impact, and quality of life. As you can see, all of these except the emotional impact were all on the milder side or on the lower side, but there was a very high prevalence of milder symptoms in this group. Also, when comparing intergroup variability, male patients with PSC had better scores compared to females. There was no difference noted in PSC PRO scores between patients of different ages, with or without IBD, and also specifically ulcerative colitis, Crohn's disease, or FTI and oral FTI. Presence of cirrhosis and complications of cirrhosis definitely worsened the PSC PRO scores pretty significantly. In another study where they administered SF36, which is a short form health survey, and PHQ-9 surveys to patients, they found that their patients' quality of life was pretty significantly impaired by pruritus. The graph A shows the SF-36 scores, where different parameters are physical functioning, physical health, bodily pain, social functioning, emotional and role functioning, and overall mental health. The negative sign indicates absence of pruritus, and more the number of positive signs, more severe the pruritus. And as you can see, it was pretty compellingly impairing the quality of life in patients with PSC. Now, switching gears a little bit and talking more about autoimmune hepatitis. Like I mentioned ahead, we do not have any validated scores or tools to measure patient-reported outcomes or health-related quality of life in autoimmune hepatitis. And there is scarcity of data or studies looking at these. This one is from a German study that studied the health-related quality of life, and specifically more psychological or emotional symptoms in these patients. As you can see in this graph, both mental and physical health-related quality of life was worse in patients with autoimmune hepatitis with or without cirrhosis when compared to arthritis. The physical component score was not significantly worse when compared with general population. However, the mental component score was significantly worse in patients with AIH when compared with general population and patients with arthritis. This was pretty significant, as we always think about the inflammatory rheumatologic diseases as affecting your physical and mental health. And when you compare our patients with autoimmune hepatitis with them, they are pretty similar. They're right there, or they are even worse. Severe depression and anxiety were significantly more in patients with autoimmune hepatitis. And as you can see, major depressive syndrome was almost 10 times more in patients with autoimmune hepatitis compared to general population. And it was right there compared to inflammatory rheumatic diseases. Some of the factors that positively correlated with depression in our patients were concerns regarding consequences of their liver diseases, female gender, and steroid use. As you can think, concerns about whether the liver disease will progress to cirrhosis, whether they'll need transplantation, death, or even passing it to future generations contributed a lot to depression, and as we'll see in the next slide, also to anxiety. Female gender and steroid use were both kind of pretty significantly affecting the mood in these patients. Anxiety was also worsened, like we talked about, with concerns regarding consequences of liver disease. Also, concerns regarding alcohol stigmatization formed a significant proportion of anxiety. And this does not apply to our population here in pediatrics, but this is something very important as they grow to become adults, and how this will affect them. To conclude, we definitely need more tools to assess patient-reported outcomes and health-related quality of life in these disease population. We have to recognize that even though it is treatable, and even though we have been able to, control them, and less patients with autoimmune hepatitis are requiring liver transplantation, it's still a chronic disease that they have to live with. And our therapy should include goals where we attain good quality of life for them as well. We usually focus so much on our labs and imaging that we need to remind ourselves to focus more on what is your quality of life and functioning. mental and physical impact of this disease, the medications we use with it, its progression, and is huge, and it is comparable to inflammatory rheumatoid diseases, and we should not ignore it, and we should focus on it. Here are my references, and once again, I thank you, everyone, for inviting me and allowing me to speak here. Thank you.